So this is the video of laparoscopic appendicectomy, the appendix in retroileal position. So this is the case of acute appendicitis, and we are taking emergency appendicectomy. So this is the suprapubic port. I'm making a suprapubic port now. So this is the view from suprapubic port, and the omentum is covering the right iliac fossa. I'm taking the omentum up to the proper abdomen cavity, so that ileocecal junction is being exposed. You can see the cecal wall edema. You can see the edema there. And I'm taking out the bowel. That is the ileum. So that is the ileum, and it look like IC junction. So that is the ileum and cecum. So I'm trying to take out the ileum, and you can see I want to make a right hand port. Sometimes it will be little above the right iliac fossa, or sometimes just below, or at, now you can see the pathology site. So that may be the appendix. So it is just below the. So I'm making a right iliac fossa port little bit below the so that it will be correct level. Otherwise I have to come down from the port. I have to come down and then work. If I put above, that's why after identify the pathology site, now you can see this is the port setup, and you can see the head end, foot end, and umbilical camera port, right iliac fossa, and suprapubic port. So now I am separating the appendix, mesoappendix, with the suction nozzle. So it is being separated, and you can see the ileum is taken outside, taken up, and it is a retroileal position. And you can see this is the epiplaque of the colon. It is adherent to the cecal wall. It looks like a adherent to the lateral wall. So it's look like a developmental adhesions. So all edematous tissue. So that is the inflamed edematous appendix. So the right side of the patient table is tilted up, and the patient head and down, so that all the small bowel is placed in the proper abdomen cavity. And sometimes I used to keep a sandbag, small sandbag below the right iliac fossa, so it will elevate the cecum, and so that base of the cecum will be elevated, appendix will be seen nicely. Or we can tilt the table right tilt up, so that all the bowel will fall away, so that ileocecal junction and will be seen exposed nicely. So this is the developmental adhesions I am releasing with the harmonic scalpel. You have to be very careful. Your harmonic blade, lower blade, should not injure the cecal wall or the ileum. So that is the mesentery and thickened mesentery with the fat, thickened fat on the ileal side. So I'm separating the attachment layer by layer, and then I'm dividing it. If you hold very thick, it will produce a lot of heat that will go to the cecal wall. So that's why take it like a small layer, and then do it with the maximum current. We won't cut the this tissue, that's all. There is no need to coagulate. So that's why use minimal energy and then divide the tissue. Otherwise scissor is ideal. So if you have some extra port to hold this fat, you can able to see the base of cecum nicely. So that is the appendix. This is the cecum. So this fat is coming our view. So now this is the peritonized appendix. That is the free lying appendix. So this is my observation. All retroileal appendix, the base of the appendix is peritonized. So it look like some cecum base, cecal base in the peritonized portion. And most of the time, we put a loop on the. Sometimes we leave the appendix. That's why retroileal appendix means, imagine, keep in mind, 2-3 centimeter of appendix is peritalized. So we have to open the peritoneum above and below, or you mobilize the cecal, base of the cecum, and then lift the cecal wall, lift the cecum, and then you identify the base. And this is a free lying appendix. If you ligate at the end of the free lying appendix, that means you are leaving some portion of the appendix. So I'm taking the division of the mesoappendix. You can see how much edematous mesoappendix is. Even with the bowel, long open bowel grasper, long jaw bowel grasper, I'm finding difficult to hold the mesoappendix. I'm trying to take out the divide the mesoappendix. Harmonic scalpel is ideal, or you can use any other energy device like a ligature, NSEED, or Allen forceps. Anything can be used. Any energy device is better. Bipolar alone is not good. Combination of bipolar, monopolar you can use. Sometimes if you have any vessel is bleeding, you have to apply clip in that situation. So the energy device is better to divide the mesoappendix. I'm going close to the appendix wall. I'm separating the mesoappendix now. So the inflamed edematous appendix, this type of some exposure problem might be there, and there is no need for extra port. Sometimes that is also not much useful. If you have a if you want to retract the omentum or bowel, you can make extra port. Just to hold the mesoappendix is no need for extra port. So this kind of fat to be retracted, then extra port is ideal. So again, I'm going come close to the taking the appendix up. I'm going close to the appendix. I'm dividing the mesoappendix. This is almost unedited surgery, so that the learning is good. If you see the unedited surgery, and I'm marking the structure, and then I'm giving voice to the surgery, so that it is a good learning video. I want to make a educational surgical video, so that is the aim. So that's why I'm keeping. I don't want to 5 minutes or 10 minutes edited video. So all the steps where it is finding difficult. Sometimes we find we'll take some time to decision making. That is also that video, that portion also I left it. So entire video you can able to see without any editor. Very minimal editor. Only the camera cleaning portion, and I'm waiting for some instrument. That kind of portion will be edited. That is called additive editing. So subtractive editing I was not done, only additive editing. So I'm separating the mesoappendix is separated. That mesoappendix is coming and then falling on the appendix, so that I'm not able to proceed. So I'm dividing the mesoappendix, the excess portion of the mesoappendix I'm dividing, and then at the end of the surgery I'll take it out. Use minimal harmonic scalpel level 2 or level 3 to divide the mesoappendix. So that will make a good coagulation effect, sealing effect. I'll kept it there. At the end of the surgery, I will take it. So on and off, you have to clean the field. Keep suction and then clean the field. Always, if you keep it clean, identification of anatomy is better. The cleaning is not a waste of time. It will make your vision better. All the fumes will be clean, so the camera vision will be better. And then you can clear the fluid around the operated field or blood around the operated field. Again, your anatomy view will be better. So always in acute case, try to clean on and off every 2 minutes, 3 minutes, 5 minutes. You clean the field and then proceed. That will make very good surgery. So I'm reaching the. It looks like conical cecum. Sometimes the cecal end will be conical. So it looked like a base of the appendix now. See, that is the cecum. So it looked like a base. So that look like a base, but it is not a base. So from here, the peritonized portion of the appendix is started. So that is the key features of key findings of retroileal appendix. This is the second most commonest position of the appendix. In our practice we could see, and the peritonized portion will be around 2 to 3 centimeter. You have to carefully mobilize this peritonized portion of the appendix. This portion will lie on the ureter. This portion will lie on the right ureter. So if you go close to the appendix, or you open the peritoneum above and below the appendix, then you can lift the appendix due posteriorly. Otherwise, you may injure your harmonic scalpel or energy device. Heat will go to the ureter. Remember, retroileal appendix, the peritonized portion is lying on the right ureter. So almost I am going down, and I am reaching the trying to go close to the base. Again, suspicious of base. It's look like a base. It look like a conical cecum, and then this is the base. But don't believe. You have to mobilize this is better way to go is, don't go close to the appendix. Sometimes you may injure the ureter. Some dense adhesion is there. Ureter also will be elevated when you are lifting the appendix. Then ureter injury will be likely possible. So what I do, so I used to mobilize the base of the cecum. So it will elevate the cecum and the appendix base, so that the cecal injury will not be there. So you can see now how much thick the peritoneum is. It look like, sometimes you may think that the cecal wall and the peritoneum, thickened peritoneum is mimic like a cecal wall. It's look like a same. Maybe you may have this experience, the thickened peritoneum, and then it look like a cecal wall, mimic like a cecal wall. So again I'm cleaning, and then I'm checking that. So I don't want to go in this, it is like a little bit cave, like it is going inside. If you go there, sometimes you may injure the posteriorly you are going, and then your harmonic will injure the cecal wall, posterior wall of cecum, or it will injure the ureter. And that's why better you mobilize the base of cecum, and then mobilize this portion of the appendix. That is my suggestion. So again I'm checking. So this is the time now I'm taking for a decision making, whether we go like this, or you can go like this, no problem. And for a teaching, I want to go. If you go even in difficult situation, thickened or any mass is there, you can able to apply. So if you lift the appendix, the base of cecum will be peritonized. No, it is not will not be lifted. So what happened? You may leave some portion of the appendix. So normally the base of cecum will be mobile. So if you lift the appendix in subcecal or paracolic, you will able to see the cecal base, but here it is a peritonized. So that's why I am mobilizing I am taking the base of peritoneal attachment on the lower inferior surface of the cecum, and I am taking the cecum up. I am mobilizing posterior cecal wall. From the retroperitoneum, I am taking the posterior cecal wall. You can see it's very easy. Only 1.5 centimeter peritoneum divided. You can see the entire cecum is coming up. You can see the psoas muscle down. Down is the psoas muscle. See, that is the iliopsoas muscle, and I am going towards the base of the appendix. And the thick peritoneum also, I am just taking down separate, and then I am cutting. Sometimes the gonadal vessel also will be coming here, but that will be little on lateral side. But anyway, you make don't any thick structure, make it like a layer by layer and then divide. See, I am making like a layer by layer. So it is very much, you can very much confident that you are not injuring any structure. So sometimes you can able to see the ureter below when you are pushing down the fascia, the ureter you can able to see. So now the base of cecum is lifted up, and now you can see that is a stretched out lateral the peritoneal attachment on the base of cecum and the base of the appendix. So I'm making it the thick tissue layer by layer, and then I'm dividing so that it will not take a high current. So underlying structure injury will not. You can see some tubular structure. The white color is seen. It may be some vessel or the ureter, and since we are going close to the cecal wall or appendical wall, and then my left hand is giving a good traction, the current will not go to the appendix or a cecal wall. So it is safer procedure. So in a retroileal appendix, try to do like this. So you will take the entire appendix, and cecum also mobilize posteriorly, so that when you apply loop, if you lift the appendix, the cecal will come up. So you will not leave any portion of the appendix when you are doing appendicectomy. See, it is lifted from the retroperitoneum. Now you can see it has come. So almost around 2 to 3 centimeter of the, so that is the base, that is the base. And here also I have to do some dissection from the mesentery side. You can see some vessel supply is there from the mesentery. I cannot leave that one. Yeah, if you leave that one, you cannot put obliquely loop, that will not be tight. So you have to mobilize the appendix circumferentially till the base. So now you can see, the cecum is coming up, the base of cecum is coming up. So you can give traction and then see all around. If you are leaving any portion of appendix, you can able to divide. So I can go up to that level. So the instrument suction tip that level. See, I am taking the thin peritoneum first. Now I am dividing the vessel. First peritoneum, then vessel. On and off suction, and then harmonic, suction and harmonic like. So now you can see that is the cecal posterior wall, that is the base, and I could see the base all around. Still some portion of the tissue is there in this region. So I have to take down the tissue. You can see the thick fat is covering on the base of the appendix. If I put one trocar, extra trocar, 5 mm in the epigastrium or in the upper abdomen, left hypochondrium, this fat can be retracted, so that I can do. So now you can see it is a entire base of cecum, posterior wall of cecum, and the appendix all around. I can all the side I can able to see nicely. So that is the base of the appendix. I am milking it out. So now you are confident that you are not leaving any portion of the appendix. And if you try to mobilize the base of the cecum like this, small portion of the cecum I mobilized in this case, and then this will give you confidence that you can go to the retroileal appendix in a very without any difficulties. Retroileal means you have to mobilize the entire retrocecal appendix, without any difficulty. Retrocecal appendix means you have to mobilize the entire cecum and part of the ascending colon, then only you can able to get the base of the appendix. So if you mobilize, if you have a retroileal appendix, mobilize part of the cecum, then retrocecal appendix is easier. Now you can see exactly at the base I apply the loop. I am not leaving any portion of the appendix. Even if you leave 1 centimeter, it will produce some appendicitis, and the patient will have pain on and off. Particularly this type of acute, the infection will be there. That will definitely make stump appendicitis. This case, if you apply the loop in near the peritoneal covering, that means you are leaving around 2 to 3 centimeter of appendix. Definitely, it will produce stump appendicitis. The second loop I will make around 2 to 3 mm distance between the first loop. And then this tip area, the mesoappendix is not divided. It will not come through the trocar. And this case, it will not come through 7 mm. I have to convert my trocar into 10 mm umbilical trocar. After that, I put a port closer also. So I can take it out after dividing this. Otherwise, if you feel that it is very much inflamed, it will not come through 10 mm. Then take an endo bag, plastic bag, place the appendix in plastic bag, and then take it out. Most of the time, if you go close to the appendix, you can see there is no mesoappendix. Only appendix is there. If you go close to the appendix and then divide the mesoappendix, and it will come through 10 mm. Now you can see the base very clearly, very nicely ligated. Double ligation is done. I'm not leaving any appendix, extra appendix portion of the appendix. So it came through the 10 millimeter port. So on the divided mesoappendix also I removed, and then betadine soaked gauze piece. So some question have asked or asked the previous video. This is necessary. The exposed mucosa, I sterilized the exposed mucosa, and you can see that is the base of the dissected area, and that is the psoas muscle. Below this fascia, the ureter will go. So that is the area of ureter. That is the area of ureter. And another question was asked whether suprapubic port you can able to show the pelvis. Now you can see from suprapubic port, I am seeing the pelvis very nicely, and my right hand port retracting the rectum or sigmoid colon. Now you can see the pouch of Douglas. This is the view from the suprapubic port, and the umbilicus camera working instrument suction is coming from the umbilical port. So the suprapubic port will give from pelvis, cecum, base of cecum, retroileal, paracolic, subhepatic, subdiaphragmatic. So all the area you can able to see. So this is the bowel walk. I am doing a bowel walk, 2 to 3 feet. Sometimes we made around 1 or 2 meters length of bowel. We used to walk, and this is a localized, just acute. It is not a perforated. There is no infection in other part of the area. So that area I washed, and then once I check the Meckels, and then I'll come out. So I'll keep the bowel in a normal position. I keep the patient head and up, and then I place all the bowel to the pelvic pelvis, and then I cover this dissected area with the terminal ileum, not on the omentum. Don't keep the omentum there. Omentum is act like a band. It may produce some obstruction, and place the bowel to the pelvis, reorient the bowel. So you can see the mesentery, and then the pelvic terminal ileum is covering the, so that is the thick fat. Ileum is covering the, that is the dissected side. You can see retroileal position of the appendix is very clearly seen now. So that is the appendix area. So this is the retroileal appendix in acute appendicitis, laparoscopic appendicectomy done. Thank you so much.